Good afternoon, and welcome to Grand Rounds here at Mary Greeley Medical Center. And I am honored to feel so at home that I get to introduce myself here as an outsider this time, because I was so warmly received into your community 2 weeks ago here for a different session on social media and ethics. So it's a treat to be able to come back and to come back so soon. And thanks again to Tim and all the other assistants to make this possible here today. So I'm Lauris Kaldjian from the University of Iowa, as you can see from the front slide here. And I'm trained in internal medicine and infectious diseases. My main role at the University of Iowa at the Medical Center is as the director of the program of Bioethics and Humanities. And so I'm the main medical ethics teacher for our medical students. I also, actually, I should say, since I'm closer to Des Moines over here in Ames, that it's been a privilege for quite a few years now to be able to give 2 lectures a year to the Des Moines University medical students in their curriculum. So I feel quite connected to Iowa, even though I grew up in Michigan. But I've been, my wife and I and my daughter, we've been in Iowa for 25 years now. So I don't know when I'm allowed to be considered a real Iowan, but hopefully 25 years is sort of at least a step in the right direction. Okay, so on that note here, you can see the topic, and this is a topic when I was in discussion with some of you, when I had been asked whether I might be able to participate in your educational endeavors here, I said, well, what topics are of interest? This was one of the topics, and so this was, in a sense, the invited thing to talk about here for today. So conscientious practice in healthcare. You can see on the objective slide, going to be describing conscientious practice as part of ethics and a matter of integrity. And that's just a key point, one take-home message, and see what you think of it, right? Because these are really big, wonderful words. Kind of a lot of big, wonderful words in ethics. Justice is one, right? So who could disagree with justice? But what exactly does it mean? So likewise, conscience, what does that mean? Integrity. I actually tend to treat those two ideas as pretty much interchangeable. So if you see me flipping in and out, I think they're covering the same kind of ethical landscape. We'll talk about ways of responding conscientiously to morally controversial practices in healthcare. And then to discuss how accommodating conscientious practice can balance the professional's right of conscience and the patient's right to access desired services. So I've got some introductory slides here first, and I want to just bring to your attention a piece that was published in the New England Journal of Medicine about 20 years ago. How many of you have recognized the name of Dr. Wiesel? Right, pretty famous in certain quarters. And it's a striking piece in one of the best known medical journals in the world. And look at its title, Without Conscience. Right? So it's a striking, it assumes that everyone knows what conscience means. And then, of course, you can see what's written in some of the text that I've borrowed from that piece, where he's asking himself, where did the conscience of the physicians under Nazi, Germany, where did that go? What happened? Why weren't individuals able to resist and counteract the profound pressures? And even as I bring this up, don't get me wrong, if I had been one of those German physicians at that time, would I have stood my ground, etc., or would I have felt pressures to conform? That's the kind of thing this is talking about, right? And so I encourage you to look at that article if you're of interest. But so I just quickly tag this to say that conscience, on the one hand, it seems to be something that someone like Dr. Wiesel is saying, everybody knows what this means. Okay, so exactly to what extent do we agree or disagree with that assumption? Another point here is this is from a survey study of over 1,000 U.S. physicians. It was published back in 2011 in what was then called Archives of Internal Medicine, which is now JAMA Internal Medicine. And it was asking physicians as part of the survey, where do you get your ethics from, your moral guidance? And you can see, look at the far right, and you see the percentages. Only one of them is really high, right? It's the one where I've put the arrows, and that's a personal sense of right and wrong. That doesn't surprise me. Now, of course, you could say if this had been a qualitative study instead of a quantitative one, you'd be interested to unpack that. Okay, what do you mean by personal? Because I think that our personal sense of right or wrong, it's already had a lot of ingredients put into it, some of which are mentioned in the other items in this slide. But the point I want to make here is to say that I think conscience very much is getting at this sense of our personal sense of right and wrong. And in fact, as I was standing here, I was reminded as I was seeing the slides that flipped through in this rotation fashion, what's the motto of Mary Greeley Medical Center? Do the right thing, right? And I don't know what group came up with that, but at the same time, did they say, maybe should we put parenthetically under that, and don't do the wrong thing? You could have. I mean, if you just want to, I think it's assumed that that's what that means. And so this idea of right and wrong, I think actually I've seen a lot of mottos in a lot of medical center, publications and advertisements. I've never seen that one before. Do the right thing. And I think it's actually really powerful and remarkably directly related to what we're talking about. So part of what this question of conscience gets at then is, do the right thing according to whom? That's what this is about, okay? And it's going to be about, okay, what does it mean for I as an individual, you as an individual who works within a hospital, who plays a role within a society, within a state, within a country, within a world? How do I as the individual relate to all that? So we're going to be talking about some really big ideas and also some ancient ideas, but making it very practical in the present time, okay? So we'll cover a lot of ground. And this slide here, you can see it and you'll quickly recognize, okay, now here we go. Here are some areas that are contentious. But this is what I think part of this discussion requires, is we need to be honest about this. And you can see how I've titled this slide, practices that may be morally controversial for some healthcare professionals. I think that's a true statement. And that's true based on just reading a newspaper, going online, right? I could back up that statement in all of these regards. And you can see how many different areas are, at least for some healthcare professionals, at least potentially controversial. And I would suspect that if I had to guess, I'd guess that there's probably each one of you would, at least in one of these areas, you might say, yeah, I'd have some questions there, maybe some concerns, maybe reservations, maybe prohibitions, depending upon where you stand. I don't know, okay? But I think that this is the kind of terrain that I'm talking about now. But now in the rest of the talk, I'm actually not going to be specific about any particular application. But these are areas that certainly I'm familiar with in my reading about, writing about, teaching about ethics. And let me add that I've had any number of very direct personal conversations, especially with medical students and residents, who have approached me and said, hey, Dr. Kaldjian, can we talk? I've got a situation and I'm not sure what to do about it. So this is a very real issue, especially when you're dealing with trainees who feel very disempowered and at times really threatened by the power structures, because they're thinking, uh-oh, if I speak up and say that I don't feel comfortable with this situation, it's going to be held against me. So that's how serious this is. And so I've got enormous respect for our junior colleagues who feel threatened by this. And at the same time, I think there are also plenty of people who are not further down the hierarchy who also feel very uncomfortable, because to a certain extent, there are always pressures to just go along with whatever the majority view is, with whatever the institutional policy is, et cetera. So we're going to talk about conscience and integrity here. No, this is a really important point just to make right up front, because I think that some people who've thought about this, they can be concerned about discussions about conscience because they're thinking, wait a minute, now it sounds to me like you're going to give a license to individuals to just do whatever they want to do, because they're going to say, this is what my conscience says, and therefore I don't have to do that. As if it were sort of the Wild West of morality where, hey, everybody, you just each to their own, as opposed to, wait a minute, don't we have professional standards? Don't we have expectations? We have to have enough common ground, et cetera. So actually on the common ground, what I also like to point out is the good news here is, 95%, 98%, you choose the high number. Most of the time, we all agree on, come on, this is what it means to take good, proper care of a patient. And so I don't, sometimes people, I have various occupational hazards in doing and teaching ethics. And one is we tend to often go immediately to the areas of conflict and debate and argument, right? But as I say to students when I'm introducing them to some of these things, I say, listen, if you walk down the hallways, the wards of our hospitals and clinics, you don't listen to one argument after another, room by room, about some ethical disagreement. No, most of the time people are agreeing. But I think all of you who are clinicians in this room, you know that actually disagreements do happen, and they happen in various ways. The one quick example I want to give right now, because what I also want to say is it's one thing to have an ethical disagreement with somebody and say, well, that's not what I believe, or that's not how I see it. But you can somehow still accept, okay, so we have to sort of agree to disagree, but we can still work together in the following sort of ways. When we're talking about conscientious practice, at least I would recommend we treat it as something that reaches a certain level of seriousness, that now affects you and your sense of your own identity as a moral human being. So the stakes are really high. So I'll give you an example. Once I was talking to an internal medicine resident who is post-call, frustrated, exacerbated, exhausted, the usual kinds of post-call package. But the reason he was particularly upset was that he was caring for one particular patient on his service in the ICU. And he thought to himself, this makes no sense. This man is dying, and his family should accept it, and this is a futile approach to care, et cetera. You're familiar with this, the so-called medical futility. And I first tried to listen well and let him vent, right? And then I looked at him and I said, well, would you say that your participation in his care is compromising your integrity? And literally, he relaxed his shoulders and he said, no, I wouldn't go that far. And I said, okay, well, that I'm glad to hear that. Because what's the contrast? I mean, think about it. And this may have happened to some of you. If you were, especially in an ICU setting or even on a ward setting, one of the more common sort of ethics consults has to do with code status, right? And a family or a patient who's insisting on full code, and the team is thinking, that would make no physiological sense. They are so compromised that the thought of going to their bedside in an arrest situation and doing compressions is such that a given clinician might say, I will not be the one doing those compressions because that would compromise me. It makes so much nonsense, right? So that's a question, I think, for each one of us as clinicians, whether something is compatible with our sense of what is good and right, reasonable, et cetera, and professional. So this is the kind of thing we're talking about. We're not talking about just preferences or styles. We're talking about things that really matter and give us our sense of our own credibility as moral agents. I like often to go to the dictionary and just say, okay, let's remind ourselves what the dictionary says conscience is. A sense or consciousness of the moral goodness or blameworthiness of one's own conduct, intentions, or character, together with a feeling of obligation to do right or be good. I think that's a very helpful definition, actually. It actually captures what we're talking about here to a large extent. And it includes, I would say, I would crystallize it down to an ability to perceive the good and right realm. That's the moral perception. A sense of self-judgment of my own role or place in this situation. And then this sense of moral obligation. it's not just like I'm a bystander saying, oh, that's interesting, like watching a sports game, as if to say that, yeah, you could like it or dislike it, but you wouldn't say you have a moral obligation to make sure one team wins and one team loses. No, that's not what we're talking about. So where did this idea of conscience come from? And is it a religious concept, a philosophical concept, or both? And of course, you'll see on these slides I'm about to show you, I'd say it's very much both, in different ways. Well, so see what you think about this. So if you go back to ancient Greece, at least in some accounts, you read things like saying that conscience was an understanding of a universal human experience of inner pain related to actions that go against human nature. Right? That's just one example. Here now is a book. If you're interested in the history of these sorts of things, I highly recommend this fascinating, in-depth account by an Oxford University intellectual historian named Lauris C. Actually grew up in West Michigan, but ended up in the UK for his career. And it's entitled, as you can see from that book, Inventing the Individual. And his argument in this book is that in Western civilization, prior to the introduction of the Judeo-Christian tradition, society didn't actually have an understanding of something that we call the individual. It's this phrase. People say that's like asking a fish about water. A fish doesn't understand what water is because that's just the world it inhabits. We inhabit a world in which we don't wonder about what an individual is. So it's hard to imagine how you could be thinking about life without a sense of the individual. But in fact, some of you might be wondering, well, what if you didn't have the individual back then? Do you know what the unit of value in a society was, say, in ancient Greek or Roman culture? If it was not the individual, what was it? The family or the tribe or the city-state. It was the group, not the individual, interestingly. So it's a really fascinating observation. And in the heart of this understanding of what the individual was an understanding of what conscience is. You can't separate the two, they're inseparable. And now with the introduction of the conscience as part of an individual's reality and existence, that conscience now, as understood by the individual, was set up in tension with and potentially in opposition to the society or the social group. So, think about someone like Martin Luther King. When I think of Martin Luther King, I think of an individual. Obviously, he worked with a lot of other individuals, right? But as an individual, someone who had the courage to stand up and speak against a whole nation, right? But speak for something. But the point being is this notion of protest and speaking up as an individual, as opposed to saying, "Oh well, I'm just part of a group, and so I kind of go along with the group," as opposed to, no, the individual speaking. And any of you, if you know anything about the history of not Martin Luther King, but Martin Luther, many people, not just in religious contexts, but in secular sort of historical political philosophy contexts, would point out that he was probably the first profoundly momentous example of this kind of individual protest when he was on trial. And he was expecting to be executed at the end of that trial, and he wasn't actually. But he was being tried by the highest authorities in the secular realm and the religious realm of his time. But so that idea that's so basic now in our democratic understanding in terms of democracy, of how the value of the individual is such that the individual is allowed to speak up and to be counted in that way. So let me give you now, speaking of the Judeo-Christian tradition, here's an example from the Second Vatican Council. So here's a religious and in particular a Christian description. In the depths of his conscience, man detects a law which he does not impose upon himself, but which holds him to obedience. always summoning him to love good and avoid evil. The voice of conscience, when necessary, speaks to his heart. Do this, shun that. For man has in his heart a law written by God. To obey it is the very dignity of man. According to it he will be judged. Conscience is the most secret core and sanctuary of a man. There he is alone with God, whose voice echoes in his depths. So that's a very religious and as I said, Christian account. Some of you may resonate with this. Others of you might say, that's not me. I can appreciate others might have that understanding. It's not my understanding. But I think that certainly is part of the culture, as I'll come to in a moment, that has impacted Western society and in particular this country. So by contrast, I don't know if you've ever encountered the name Martha Nussbaum, but she had, I think, for most of her career at the University of Chicago. A very famous political philosopher, has written many books. You can snoop around and learn more about her online. She has a book entitled Liberty of Conscience, and in that she says that our moral and spiritual faculties, whether we call them conscience or soul or human dignity, deserve respect wherever they are found. Conscience, she describes it as infinitely precious as a human characteristic that grounds human equality, demands universal respect, and justifies the argument for religious liberty and equality. So she's writing as a secular, non-religious political philosopher, and that's how strong this statement is. I also had occasion to come across this. Have any of you been to the National Constitution Center in Philadelphia? I haven't either. But I've learned about it because I was at a conference overseas, actually, in January, and this gentleman, whose picture you can see here on the right, that's Jeffrey Rosen, who's the director of this entity. It's a nonprofit group. He gave a wonderful talk there, and so I was snooping around online, and you can just see, if you can be glancing at this as I'm talking, the way this website at this National Constitution Center describes conscience and its significance for the founding of this country is really quite striking, and it's very clear. So you can go to that website if you're interested to learn more, but the connection between religious liberty, free speech, free press, freedom of assembly, and the right to petition, as it says here, the founders viewed these as natural rights that come from God or nature, not from government. They believed that our opinions were the product of reason, that reason was the power of the mind to think, understand, and form judgments, and that this process shouldn't be controlled by government. And these things then are at the core of freedom of conscience. So we're not talking about something that's just academic or just some people are into. The argument here is we're talking about something that actually our country depends upon, or at least previously has depended upon. Okay. So now a philosophical description. And of all the different descriptions I've come across in trying to do a fair amount of reading on this topic, this is one by a philosopher who wrote back in 1940, a guy named C.D. Broad. And I actually find it nice because there's a certain simplicity, at least at the first pass level of this, because it talks about three dimensions of conscience: moral reasoning, morally directed emotion, and moral motivation. And you can see the sub-details in that. And I think I would ask you, would each of you be able to agree with me that you have at least a few times, if not many times, like some of us in our lives, have actually had an experience of conscience such that you were in a situation that had already occurred? I'm not saying conscience can't work in advance of action. I think it can, but it's more typically after something has happened, right? As part of the reflective process. And so have you not been in a situation where your moral reason made it clear to you that you believed that you had done something wrong, right? So it's something you could actually think about, not just feel, but think. But you also had emotions related to that. So you, as they say, you felt what it feels like to have a guilty conscience. And if you did, how'd you feel about that? For some people, it's actually the worst, the most negative emotion they've ever had in their lives, right? And then, did you not also have the sense of motivation, meaning that this thinking and this feeling were spurring you on to do something? For instance, to go apologize to someone for what you did or said, or didn't do or didn't say, right? I find this really experientially, phenomenologically valid. It certainly reflects my experience of life. So I just offer that to you, and if that's not your experience, then I accept that, but I expect it probably is. The next point to make here, though, is it has to do with the first aspect, moral reasoning. If you agree with this assessment of what conscience entails, it means that because conscience involves reason, conscience is part of ethics, right? So it's actually right in the mix there. And because it involves reason, conscience is not merely a private feeling, desire, or preference. So it's not just one person saying, my feelings are such that I can't do X, Y, or Z, but it's rather, I can talk about reasons and explain my reservation or my disagreement in ways that, because reason now I can share my reasons with you, you can share your reasons with me, right? That's very different. Whereas, hey, it's like imagine two people at an ice cream counter, and I really like chocolate, and you really like vanilla. Are we going to have a conversation about that? Can I give you my reasons for chocolate? It's more like, no, I just like it, and you just like that. Or it's not unlike, I know we have neurologists in the room. If a patient is describing their headache, you can't quite feel their headache. Now, if you've had bad headaches in your life, you certainly have a lot more basis for empathy. But medicine's full of these situations where patients are telling us stories. And it's really hard sometimes if it's just a matter of feeling, which so much of taking a good history is, because that's what symptoms, as opposed to signs in healthcare and taking the HBI are about. You get what I'm saying yet, though, that reason, we can talk about reasons and should. Now, I also want to quickly add, there's a certain paradox that's really important to keep in mind, that conscience for each of us as individuals is authoritative. As we say, we're supposed to follow our conscience, but it's also fallible. I might be wrong, you might be wrong, even in our conscience. So there's a certain mystery in that, but remember a paradox, if you look up the definition, it's a seeming contradiction, it's not an actual contradiction, which is to say that there's a way to understand how these things can come together, which I'll come to in a moment on the next slide. But the point being is that our consciences, just because I say to you, well, my conscience doesn't allow me to do that, that doesn't mean that I'm right. It just means that's what I'm telling you. And so that's the next step, is to figure out how confident am I that I really am right in this regard. Okay. So dealing with the fallibility of conscience, I appreciate the traditions that talk about the need for a properly formed conscience and a properly informed conscience. And then also we can talk about other virtues like humility, right? Especially within a professional environment where we need to be able to work together well and to be considerate of each other and respectful. And even in the midst of deep disagreements, I think one of the hardest things for some of us in life is when we have a deep disagreement with someone is, how can I now speak respectfully to another person who's involved in this situation and I owe them an explanation? How do I go about that? Right? I think I once, when I took on taken on various administrative positions in my professional life, and one person once handed me a book and said, you need to read this book. And the title of the book was Difficult Conversations. Right? Learning to be a wise administrator, to know how to have difficult conversations. I get that. And it's, some of you in administration are great at it. Some of you are not in administration because that's one of the parts of life you'd rather not have to have built into every day of your life at work. Okay. So the point here now to say, though, is that just because I say my conscience is directing me in a certain way, that doesn't justify itself. I still need to now engage ethically in giving reasons one way or the other. But the point about conscience is that it's sort of like a final common pathway. It's saying when you've decided your conscience is saying yes or no to something, that's reflecting, I would suggest, that the best you can do is that. It's representing your moral best. And that's why the saying goes, you should always follow your conscience. Not because it's perfect, because you just can't do any better than what your conscience is doing. And I think that's why we always want to say that, this idea of a properly formed and informed conscience. You can't take shortcuts here. You have to do your due deliberation and make sure you've done your conscientious best. And even in our the little evaluation form that's used to evaluate medical students on rotations at the University of Iowa, at the end it asks you to select words that best describe the student. One of them is conscientiousness. So what is a conscientious person? I know it's got a different connotation in that setting, but it's someone who's actually really careful and thoughtful and thorough, right? And actually figuring out what they need to have done to justify whatever they're doing. Okay. As I already pointed out, I think there's a lot to be said about incorporating integrity and integrity with conscience as an idea. And I like the way the word integrity suggests the word integration. And I won't say more about this now, but there's some really thoughtful people who've written about the need for unity in the moral life as so-called undivided self, the danger of compartmentalizing, so you have a work self, so-called, and then an at-home self or an at-church or synagogue self. You know what I'm saying? Is this idea of living a double life almost in a moral sense. And then there's also the whole literature, and I'm sure many of you know quite a bit about this, especially our nursing colleagues in the room. The literature on moral distress, which really came from the nursing literature initially, is one take on that is to say that it's about questions of conscience, but it's used, the language is the moral distress language. And at some levels, it can be a matter of the tension between individual values and so-called work values. And then there's, of course, these days, quite a bit of discussion about the connection between moral distress and burnout issues as one of the many causes of professional burnout. So I'm a big fan of trying to bring these different kind of areas together. Then just in passing, I just want to point out that what we're talking about when in ethics, in bioethics, medical ethics, by and large, I think the three most common approaches would be either a principles-based, the so-called, 4 principles, beneficence, non-maleficence, autonomy, justice, or a utilitarian-based, which is an outcome-based, or less commonly, but for some of us very centrally, a virtues-based. And then the one here that's under circumstance, narrative ethics, is an area that actually I enjoy engaging quite a bit because I think that I agree with those who say that in telling stories, it's a very powerful and important way to talk about and to do ethics, right? To take stories seriously because stories reveal so much about what it is to be a human being and to be a moral human being. But the point here is to say that conscience is really over here in the virtue domain, because virtue draws attention to you as a moral agent, as opposed to the way principles focus on actions that are right or wrong. And of course, utilitarianism focuses on outcomes that are good or bad. But virtue, in a sense, turns the camera back at you as a moral agent, which is really important. And of course, we all know that, but it's strange. So often bioethics ignores that in a kind of bizarre way. All right, so there are a lot of interrelated dimensions that I've already been tagging, and I put them up in some kind of starry constellation here, right? This idea of reason, feeling, motivation, ethics, identity, and then foundational beliefs and values. I often talk about foundational beliefs and values as saying, okay, instead of just saying, okay, yeah, we all agree with beneficence, non-maleficence, autonomy, and justice, until, of course, you start unpacking exactly what they mean. But at a mid-level description, we can agree that those are important domains. What's underneath them that actually allows us to unpack them? That's what I'm calling the foundational beliefs and values. And so you can see here, I've just tried to use a pictorial illustration. We've got decisions and actions on the highest surface, principles and virtues in the mid-level, and then what's underneath that. And those foundational beliefs for any person might be described as religious. They might be described as non-religious or philosophical, right? So it's whatever your best, deepest reasons are for how you understand what is real in this world and what is good in this world. So what kinds of things am I talking about? You could look at this list here. What are your beliefs about human nature, the value of human life? Persons, who counts as a person? Conscience. I have learned, because I've engaged this question of conscience a lot. Some people take conscience more seriously than others. I've learned that very directly. Freedom. What exactly does it mean? What does justice mean? What is health? It may strike you as strange to hear it, but if you actually start reading about concepts of health, you realize there are some actual interestingly competing ideas out there, and we won't go into that further now. What's the meaning of suffering? And what's the place of suffering? And when should the goal be to eliminate suffering, even if it means ending the life of a patient, as in assisted suicide or euthanasia? Those are very real questions in certain jurisdictions. And what's the meaning of death? Definitions of death, the meaning of love and compassion, and what's the so-called patient's good? Some of us, I've been following someone like Edmund Pellegrino, Dr. Pellegrino, the good of the patient is a wonderful refrain in many of our heads, right? Because it's the idea is that's the bottom line. We're trying to promote and pursue the good of each patient one at a time. But what does it mean to help or harm a patient, right? That's, if you think about that initial slide I showed about morally controversial areas, why is it that people don't seem to be able to agree on whether that's a harm or a help? That's what we're getting at here. We have disagreements about what the good is going to look like. So what we're doing with treatments or tests is oriented toward goals of care, that's oriented towards concepts of health, and that's oriented towards human flourishing. There's a lot in there, but that's just this idea of we're trying to promote our patients' good. Right? But what do we do when we have disagreements about this? So now I'm going to move rather quickly through some specific dimensions of this question of conscientious practice. And by that phrase, I mean practicing according to your conscience. So, as I've already emphasized, reason needs to be part of our understanding, I believe, of conscientious practice. It is not just feeling. And there is a really great goodness in giving moral reasons, and I've listed them here. Now, it doesn't mean to say that if you are in a situation where you need to say to someone you can't participate in something, it's not to say that, I'm not saying you have to be prepared to, write a 2-paragraph email that unpacks your rationale. No, it might be in a given instance enough to simply say, I have philosophical or religious reasons that cause me to not be able to participate. Now, that person might say, could you tell me more? And if you think that that's a good conversation to have, then you can engage in that. But there's this idea of giving reasons at different levels is really important. This is an important slide, at least in my mind, because it gets at part of what I was saying. Part of this gets at the issue of seriousness, right? Any of you who come from a Roman Catholic position may recognize this. And yet it comes from that tradition, but as you know from, medieval philosophy and whatnot, so much that's in the Roman Catholic tradition it's not so much. Let me just say it more modestly here. Certain ideas, even if they come from a religious context, don't require religious beliefs in order to make sense of the idea, right? So some of you might know this, the principle of double effect, for instance. That's another example that comes from the Catholic tradition by and large, but it's a general philosophical principle. Look at this here. So this to me is what I try to keep in mind. If a student comes to me and says, hey, can I talk to you about an ethical situation? And they're wondering whether they, in good conscience, can participate or not. I will literally walk through these elements in my mind and articulate them with the student to help that student make their own decision about whether this is something they can do in good conscience or not. So intention, proximity, seriousness, clarity, and impact. I think that's a very helpful construct to keep in mind, just to walk through that, and this also shows how serious one should be about any claims of conscience. You don't just do it automatically. I mean, sometimes you might have been around the block on that question and you can be very quick to reach a conclusion. It's like a seasoned clinician who says, that's cellulitis, right? They don't need more than 2 minutes at the bedside. Whereas a medical student might need 2 hours to figure out, oh, that was cellulitis, right? You see what I'm getting at. Okay. Conscientious practice includes non-participation, right? So if you have concluded that you can't in good conscience participate in something that others are participating in, there are different options. And part of the work of conscience is to figure out which of those options you should follow. So you could have non-participation and simply just stay quiet. You might have non-participation and simply inform someone, if you need to, that you can't participate. You might go a step further and explain, give the reasons rather than just the conclusion. And then in a given case, you might believe that even though you can't do something, you have an obligation, you might believe, to explain to the patient what the patient's options are to get that from some other source. Or there could be the so-called expectation of a referral, right? So these are the kinds of questions that come up in terms of literally very concrete issues of what do I say and what do I do? And different people will actually reach different conclusions, and it's very context dependent, at least in my experience, in terms of where people land. On the question of referrals, when I've reviewed major professional organization statements about conscientious practice, almost all of them that I can recall have an expectation that, okay, we're going to respect the individual clinician's right to not participate, but at least they have to refer the patient to someone else who will provide that service. I don't actually agree with that myself, but I honestly accept the fact that that's an honest description of where most professional bodies stand. That's part of what's open for debate and discussion in our society right now. So, and I don't know what that thought would be in your medical community, but I just put the point here to say descriptively that there are a lot of folks in our profession who would agree with this slide to say that no, referrals should be part of the way society deals with the tension between the rights of the clinician to not participate versus the rights of the patient to have access to medical services, even if they're controversial, okay? So that's a point of contention in our society. I just want to say, though, that my sense is that for those who think that, well, at least a referral is always necessary, I think it's really driven by a utilitarian argument that says you need a certain outcome, and if all you're doing is simply referring the patient, you're keeping your hands clean, so your conscience should be fine. But it's not for someone else to tell the clinician that the clinician's conscience is fine. The clinician has to reach that decision. And I think different humans are different in this regard. Some of us, we would say, no, if I'm making that referral, I am participating. I'm not doing it directly, but I mean, think about it. Think about a very different context. Say people rob a bank. If you're an accomplice, you didn't go into the bank, you didn't hold a gun to somebody's head, but you assisted in other ways, guess what? You're still going to be in trouble, right? So there are different ideas of different levels of involvement. Okay, you see that point. And I won't go into the example at the bottom. Maybe I might bring it up later as an example, but in the interest of time, I'm moving here. So this is all to say that there are disagreements about whether referrals should be mandated within our professions and within society or not. On that note, and Dr. Kitchell asked about this 2 weeks ago, the current situation in the state of Iowa. So this is copied and pasted text from House File 571, which was passed by the House a little while ago, but its Senate version is Senate File 220, and I checked as recently as I think this morning, and it's still on the unfinished business for the Senate. So I don't know if they're going to get to it. I think we have, about 2 more weeks left in the current session. So I don't know if if the Senate will take it up or not. But this is some of the language from it. And I bring it up here right now is to say, notice that in the proposed legislation, refer is defined as a form of participation, meaning to say that the conscience protections envisioned in this law would protect a clinician who says, I am not in a position to be able to refer. So that would be protected. So the current legislation includes a definition of participation that would include referrals, and not only that, but also counseling and advice and information, et cetera. It's basically, and notice this, in any way. So they're basically leaving it up to the clinician's conscience to decide what participation means for them. Also, I just wanted to point out that the definition of a medical practitioner is what you would expect, but it also includes students and trainees, right? So just to let you, especially for any trainees in the room, to know that you are explicitly protected, you would be protected by such legislation. So I acknowledge that in our society, there are important tensions here, right? The competing rights and interests of the professional's right of conscience versus the patient's right to access legal services. This is a piece from somebody who wrote a law review article, who included in that the statement that in most cases, there are ways to achieve respect for the professional's right of conscience and the patient's right of access through information and communication systems established in advance. I think sometimes they're inconvenient, but there are a lot of creative ways. Society has this in many dimensions, right? Where we have to work things out to the best of our ability, reach compromises, balance priorities and competing interests. And they're sometimes frustrating for some folks, they're sometimes inconvenient, but it's really, I think what they always do is they reflect how seriously are we taking something. And the more seriously we take it, the more we're willing to devote time and energy to doing it in ways that are trying to respect both sides as much as possible. So I snooped around your website and I found a copy of your employee handbook. And it has information about employee requests to not participate in patient care or treatment. And it says, Mary Greeley Medical Center recognizes that there may be instances whereby an employee who is directly involved in patient care may have a perceived conflict with the care and or treatment of a patient due to cultural values, ethics, or religious beliefs. The employee must notify the department director, who will make every effort possible to accommodate the request. The employee will use accrued benefit time for time not worked on his or her regular schedule. An employee may not refuse to care for a patient with HIV/AIDS or because of race, ethnicity, or religious affiliation. And then a more detailed summary is available in a document that I could not find online because I'm not employed here. So I like to, when I'm learning about an organization, I like to find out what's available. And I think our hospital has ours. I don't think ours is available in a public format, but we have a policy and it's similar in certain respects. I hadn't before come across a statement about the expectation that if one had to step away from work, that you'd have to utilize accrued benefit time. I hadn't seen that before. So I just put that up because I think it's interesting to see what different organizations are doing. And once again, I thought how interesting that doing what's right is the motto. So wrapping up here, before we have some Q&A time. Plato, about 2,500 years ago, right? Famous for a lot of things. But he said in one of his dialogues, he wrote, "It would be better for me to have a musical instrument or a chorus which I was directing in discord and out of tune. Better that the mass of mankind should disagree with me and contradict me than that I, a single individual, should be out of harmony with myself and contradict myself." I mean, don't you find it quite remarkable to think that here we're talking about something and people have been thinking about this for 2,500 years? So there's something, I find something quite consoling about that, actually, to say that, hey, sometimes we think, our times are just more difficult than other times, or more challenging, or more uncertain or something. No, these are such basic human issues. And coming from a philosophical perspective, Plato had, Socrates had, and others have had this sense of, I need to be in tune with myself to the best of my understanding. Once again, doesn't mean that I'm perfect. It just means this is the best that I can do. It's a bit of a map here, right? So this is one, I put my mind to saying, how do I see what's going on here? So our integrity or our conscience, we have it, right? We encounter morally challenging situations. We may encounter moral distress from that. And then the first question I think we always have, especially within hierarchical organizations, which all organizations are at a certain level, am I going to communicate about it or not? By moral communication, I mean talk about the ethics, talk about the thing. Because if I don't communicate and don't have dialogue, I think I'm putting myself at risk of compartmentalization, moral injury, or burnout. But if I do communicate with the right people in the right way, hopefully there can be moral dialogue and deliberation. Hopefully there can be resolution of one kind or another. And then if there is, I think we can call that conscientious practice. So this is what I'm getting at. So I think, and I had this conversation very recently with a resident who was rotating on a urological service. And there was a procedure being done, and the resident found out just about an hour or two beforehand, didn't realize what the indication for the surgery was, and then found out, and then realized, oh no, I can't be first assist on this procedure. And then had to communicate with the attending surgeon. And interestingly, that attending surgeon accepted that and didn't discuss it, sort of went on with the day, but said later on, after another case was done, said, I'd like to talk to you about what you told me. And so this resident was wondering, okay, what's that going to be about? And then later on, actually had that conversation, and the resident gave the short version of, I have religious reasons why I couldn't do that. And the surgeon simply said, okay, they moved on to discuss the next patient. But that resident, and I spoke directly with that resident, was not finding this something that they were looking forward to. Let's just put it that way, right? That's how hard these things can be. But I think that resident did a really fine job of recognizing who they were, what they could or couldn't do, and then doing what they needed to do in terms of those communications. And I was glad to hear that it went as well as it did, and there was mutual respect from that. So in summary, conscientious practice reflects a serious moral conviction involving moral obligation, moral identity, the need for respect from others, and an expectation of explanation to others. So we should be able to have conversation, not because we're going to necessarily persuade each other, but just so that we can show respect for each other by communicating with each other. And I think conscience and integrity should be understood as a fundamental part of our lives as moral persons, engaged as part of ethical reasoning, respected as a right in a morally pluralistic democracy, and supported for the flourishing of health professionals, patients, and society. So, thank you very much. And I'll take any comments, questions, rebuttals that you'd like to voice. Thank you. Anyone? Anything? Yes, Dr. Kitchell.
I noticed that not Elon Musk, but some of his Department of Government efficiency were into the Ayn Rand philosophy, where the individual is primary and the masses are not as important, and that altruism is considered a vice. How do you, and I noticed the book that you cited here talked about individual equity. So how do those cultures and philosophies clash? I was a little concerned that Doge was thinking more about the altruism as a vice when they chose some of their purges.
Yeah, I've never really studied Ayn Rand and her promotion of, shall we say, the virtue of self. selfishness, basically, right? Which is, of course, that I'd call that a vice, not a virtue, but not she. So, and I certainly won't speak to the entities and the people you're referring to, but the idea I'm very ready to speak to. And of course, I completely agree that if one takes this idea of the value of the individual and dislocates it from a complete package of virtues, you get a disastrous hyper-individualism. And it's not actually disconnected from then so-called radical autonomy on the patient side, right? This idea of whatever the patient says they should get, or whatever the professional says they should have somehow. No, so then you can start saying, what other virtues are so necessary? And so a respectfulness, a compassion. In some of us will use the language of what does love mean? How do I manifest love to my neighbor or my patient when I disagree with my neighbor or my patient, right? And also this idea of whenever, for instance, I opened up with this example of the code status and futility in the ICU. I'm a big fan of saying, when I'm talking to residents especially, who are so sometimes overwhelmed by just how difficult life is as a young doc, and they're feeling physically and mentally and in other ways just sort of distraught. And so what I'd like to be able to recommend to them is say, listen, so your patient's wanting something or the family is wanting something, you don't think it's wise, go as far as you can. So the person who's the hyper-individualistic is not going to be as interested in saying, how can I be as accommodating as possible? This also happens, actually, here's a very different context that I didn't bring up yet. I've encountered this it's not that rare, actually, especially the more multicultural our societies are becoming, is that, for instance, when you're caring for a patient, suddenly a member of the family comes to you in the hallway and says, Doctor, I don't want you to tell my mother that she has cancer. You tell me, and we in our family will decide when and how to communicate this to her. That's a very real matter of conscience, because I have in my experience, different doctors will handle those situations somewhat differently, sometimes very differently. And what I would say is that we should try to accommodate that cultural difference as much as possible. But at a certain point, a doctor might say, listen, I'm an oncologist. We're about to start chemotherapy. I, in good conscience, can't do that unless I believe my patient knows a certain amount of stuff about what's actually going on here. So, Dr. Kitchell, I agree with your concerns about individualism and the common good, as well as what it is to show kindness and love to my fellow human beings. That there's a sense in which they have to come together. And in the history of this idea, remember, the reason why Judeo-Christianity was the source of this introduction was that there was a triangulation going on. Now you had equal value among human beings because they all had a relationship to God. I mean, that's the basis. So then, in the Judeo-Christian context, my goodness, there's a whole Judeo-Christian ethics that goes along with it that includes the parable of the Good Samaritan, which is the opposite of Ayn Rand, as far as I can tell. Right? So is that a sufficient sort of answer? Okay, that's a great question. Thank you. Yes, please.
Hi, my name's Lindsay. I'm with Infectious Disease here. Thank you for coming to talk. That was super interesting. I was just wondering if you had seen any changes in patients and their conscience in view of like social media becoming more of like a main factor in people's lives. I think we talked a lot about like how religion is anchoring people's conscience, but what about like maybe the social media aspect of that?
Yeah, no, can you actually, do you have any particular example in mind? I'd be curious, because that would help anchor where I'm about to go with this, I think.
Well, I think a lot of times we're running into patients now, in my experience since COVID, that are getting their opinions from social media and not necessarily anchoring in like science or even religious, you know. No, good versus bad is not coming from their religious beliefs, but stuff they've been hearing on social media.
Yeah, and I think so. So the first thing I'd say is, when I make reference to foundational beliefs and values, yeah, where do those come from? And that's why I said for some people, they would describe them very explicitly as being religious in origin. Others would say, no, that's my philosophy. I'm a Freudian or a neo-Marxist or whatever. And others might say, oh, I follow so-and-so.
Yeah.
And I think you're right. During COVID, I think a lot of us, I to this day, I can't. How many times when people would ask me, often sort of in family or friends, they'd say, "Well, what do you think about the vaccine, or what do you think about masks, or whatever?" I'd say, it's hard to sort through the data on these things, and by and large, you need to figure out who you trust, and then hopefully they're actually trustworthy, and then you follow them. I think what I would find interesting, though, in that regard is if I were actually interacting with a patient in an infectious disease context, and if I'm making a recommendation and they're not interested, and maybe I realize, oh, I just touched something quite sensitive because they're really speaking strongly. Then I think I'm more in the realm of, okay, I'm certainly, as I say to our students, we inform, we recommend, we sometimes attempt to persuade, but we don't manipulate or coerce. I might, if the patient gives me permission to have a conversation about something, if I think I can be helpful, just take even routine childhood vaccination these days. Come on, this is a really serious issue in our society. And if you look at the data in Iowa and elsewhere, in trust in physicians and in public health, and vaccines, there's been a downtick. So one by one, we have responsibilities, I think, to do our best to show our patients that we can have conversations with them, respectful conversations. I don't think I would ever have to press a question so much with a patient that it would become, I want to make sure you're declining this recommendation is a matter of conscience. Then I'll respect it. No. I've got a much more robust view of basic patient autonomy than that. Yes, I'm interested to know what their reasons are, and if it's natural to have that conversation, I like to learn what's on my patients' minds. But I think there's a certain asymmetry now, given that that we owe more to patients than patients owe to us. And that's why I think sometimes we might find ourselves, if a patient said to me point blank, "Doctor, why won't you do what I just asked you to do for me?" I owe it to my patient just respectfully, calmly, as briefly as I need to, just to give an answer. Whereas I don't think we should expect the same from our patients. Does that make sense to you?
No, it totally does. Have you noticed any trends going forward since 2020, let's say, particularly?
Well, I think the main one that I just mentioned about trust and distrust.
Yeah.
These are challenging times. Yeah. So I hear you. But as I say to students too, I think if we just one patient, one family at a time, give them one more reason to think, maybe doctors, nurses, maybe they're more trustworthy than I was being led to believe following my favorite influencer, right?
It's just so hard now because it's like for every patient that we touch, it's like, XYZ on, Twitter, Instagram, or whatever is touching thousands. Yeah. But I guess that's a story for another day.
It is, but at the same time, when they're having chest pain or abdominal pain, they're not going online. And when they're they're going online first. We're all going online, right? But what I'm saying is they end up in your emergency room and in your hospital, right? And they know then how dependent they are on the other virtues of people who want to care for them and promote their good, even in circumstances where there might be some disagreements. But as I said, I'll end again on the note, in 99% of cases, we're on the same page, and we can be grateful for that. So I want to respect the clock here. We're 3 minutes past the ending time, but I'll be happy to speak one-on-one with anybody else. But thank you very much. It's been a real treat to be with you all.